Fracture. It is a fracture at the distal end of the radius at its corticocancellous junction about 2 cm from the distal articular surface. As you can see in the given image, 2 cm above the distal articular surface, a transverse fracture line will depict the Colles fracture. It is nearly almost always occur due to fall on an outstretched hand. It is commonest fracture in people above 40 years of age, particularly common in women because of postmenopausal osteoporosis. Anatomy. Normally, the distal articular surface of the radius faces ventrally and medially. The tip of the radial styloid is about 1 cm distal to the tip of the ulnar styloid. Pathoanatomy. In the Colles fracture, the main thing is the displacements. In the displacement, we have impaction, dorsal displacement, dorsal tilt, lateral displacement, lateral tilt, and supination. The supination is not visualized on an X-ray most of the time. These displacements are almost always asked in the viva. These displacements need not to be occur as an isolated injury. It can occur with the following: fracture of the styloid process of the ulna, rupture of the ulnar collateral ligament, rupture of the triangular cartilage of ulna, rupture of interosseous radio-ulnar ligament causing radio-ulnar subluxation. As you can see in the anterior posterior view, we have the proximal shift, radial tilt. In the lateral view, we have proximal shift, dorsal tilt. Next, we have the diagnosis. It is mainly clinical diagnosis. The clinical presentation of Colles fracture is pain, swelling, deformity of the wrist. On examination, there is tenderness, irregularity of the lower end of the radius is also found. The main thing is the dinner fork deformity. As you can see in the given image, there is dinner fork deformity. The radial styloid process comes to lie at the same level or little higher than the ulnar styloid process. Next, we have the radiological features. Radiological investigation help us to differentiate Colles fracture from the other fracture at the same site like the Smith fracture, Barton fracture, and the other fall on the outstretched hand injury by looking at the displacement. The dorsal tilt is the most characteristic displacement. It can be detected by looking at the direction of the distal articular surface of the radius on a lateral X-ray. Normally, it faces ventrally. Similarly, a lateral tilt can be detected on antero-posterior X-ray. Most of the displacement are usually identified on X-rays. Lastly, we have the treatment. Treatment of the Colles fracture is essentially conservative. For undisplaced fracture, immobilization in below elbow plaster cast for 6 weeks is sufficient. For displaced fracture, manipulative reduction followed by immobilization in Colles cast is preferred. Now, the technique of the close manipulation is as following. The muscle of the forearm must be relaxed. It can be performed under general or regional anesthesia. Firstly, there is disimpaction of the fragments which have often been driven together. This is achieved by longitudinal traction given by the surgeon against the counter traction by the assistant who grasps the arm above the flexed elbow. Some displacement are even corrected by the traction around. The surgeon now press the distal fragment into palmar flexion and ulnar deviation using the thumb of his other hand. As this is done, the patient hand is drawn into pronation, palmar flexion and ulnar deviation. A plaster cast is applied extended from the below the elbow to the metacarpal's head, maintaining the wrist in palmar flexion and ulnar deviation. As you can see the process of the manipulative reduction in the given image. Check X-ray needed to be carried out. Check X-rays every weekly is needed for first 3 weeks in order to detect redisplacement. Plaster is removed after 6 weeks and joint mobilization and muscle strengthening exercises started for the wrist and the fingers. It is also necessary to check whether proper correction is achieved or not. Other surgical methods which can be used to treat the Colles fracture are percutaneous transfixation by using K-wires or an external fixator which is based on the principle of ligamentotexis, or locking compression plate can be used. Lastly, we have the complication of Colles fracture. Most patients progress rapidly to full functional recovery. Stiffness of the fingers and malunion are common complications. Other complications seen occasionally are Sudeck's osteodystrophy, carpal tunnel syndrome, and rupture of the extensor pollicis longus.